My name's Kevin Hedges. I'm an occupational hygienist with the Occupational Health Clinics for Ontario Workers. I'm also the International President of Workplace Health Without Borders. So a number of the speakers that we're going to be presenting today have also presented through Workplace Health Without Borders. And I encourage you to look up Workplace Health Without Borders to find out more about us. But it gives me great pleasure to open this session today. And we have some really great international speakers. Lisa Brosseau, first, who's a retired professor from the University of Illinois School of Public Health. Lisa has done an incredible amount of work in this area. She's also been an educator at the University of Minnesota Public Health, where she directed the industrial hygiene program. And her early research focused on performance of respirator filters. She continues to serve as a mentor and tech advisor on research projects and also consults with CIDRAP. Dr. Brosseau has authored more than 100 peer-reviewed publications. That's our first speaker. Our second speaker is Deborah or Deej Gold. Deej is a CIH and she's worked for Cal OSHA for 20 years. And she was the lead in developing the Cal OSHA standard on the Aerosol transmissible disease standard. She retired in 2014 and she worked as a deputy chief for health and in 2014 and she retired and she continued to work with unions. Deej is second, and then we've got Professor Cherry for the Institute of Occupational Medicine. I don't actually have my slide up, John, so I'm just going to have to ad-lib this. So John Cherry has been in the field for many years. He's a professor, and I believe he's with Harriet University as well. And he's a well-renowned practitioner in the field of occupational hygiene. And when I show my introductory slide, you can see more about John. The last speaker is Simon Smith. Simon has recently retired after a career in respiratory protection research for over 35 years. This started with doctoral work on sorbent media, followed by employment with respirator manufacturers. And Simon or Dr. Smith works closely with the ISRP and also the ISO working groups, international standards for respiratory emergency responders. He's also had a lot to do with the Canadian standard and the bioaerosol working group. He's also chair of the AIHA Respiratory Protection Committee. So what I'll do is I'll just quickly share my screen there. Hopefully, just share my screen just to have an introduction here. So really, like I said, I've introduced the speakers, and this is really, yesterday we had a fabulous session debating the science with some really well-renowned international speakers. And so the idea was just that we debated the science around aerosol transmission. And now we're sort of looking at the hierarchy of control, the hierarchy of prevention, also introducing control banding, and the role of infectious dose and the hierarchy of prevention. And as I said, these are the speakers that we have. Lisa's closely aligned with CIDRAP, the Minnesota Center for Infectious Disease Research and Policy. Deborah Gold has a lot to do, has led the development of these standards, and I provided hyperlinks in the introduction slide. And Professor John Cherry, Harriet White University, Principal Scientist of the Institute of Occupational Medicine. So he's doing a lot of research at the moment through IOM and through the university to evaluate the effectiveness of novel workplace interventions to protect healthcare workers from the coronavirus. As part of this research, is working with a group of clinicians, engineers, and others to develop and test a ventilated headboard for use in health and social settings. And as I said, Dr. Simon Smith is talking about respiratory protection, selecting effective respiratory protective equipment after that. And then there's a Q&A session. What I'll ask is each speaker, if they could try and keep it to 15 minutes, because we want to try and keep enough time for Q&As. Without any more information from me, I'm going to hand you over to Lisa, Dr. Brosseau.
So thank you. I don't know if people can see me or not, but thank you very much for the invitation to speak today. And I would like to thank Paul Hewitt for reviewing my slides. This is not an area of necessarily of expertise, although I am quickly learning a great deal more about exposure assessment, modeling, and using infectious dose as an idea as a way to illustrate the impact of different interventions. So I hope
we can see your slides, Lisa.
Thank you. So as Kevin mentioned, I did work as professor at the University of Minnesota and the University of Illinois Chicago until up to 2 or 3 years ago, and was retired doing a little consulting. Of course, now I feel like I'm much less retired than I was. I have published several articles on the Minnesota Center for Infectious Disease Research and Policy website, one talking about aerosols in the context of this new organism and pandemic, another talking about the differences between face coverings and surgical masks and respirators, and the third talking about decontamination. So I will direct if you're interested in more information about those subjects, you can certainly go to that website. Let's see if I can get this to move along. There. So what I'm going to talk to you today a little bit is what could we do if we thought about infectious dose? And infectious dose has been around for a while, but it's been more used in the context of tuberculosis, and maybe a little in the context of influenza, but it's not received a huge amount of interest and research for things like SARS and MERS and SARS-CoV-2. So, but I think there's more attention being paid to it in the recent past, and I think people are beginning to understand that there must be there must be a dose issue or some relationship with respect to concentration and time. And so for SARS, we thought a lot of it was nosocomial transmission, and the highest risk of infection seemed to be during aerosol generating medical procedures, where anyone standing around not wearing a respirator, a well-fitted respirator, was infected in small spaces. The expectation was that SARS-CoV-2 would have the same kinds of features, and so there has been attention for aerosol generating medical procedures. But in COVID-19, we are seeing a lot higher attack rates in other settings, but again, they're indoor clusters. And so both of those, to me, as an industrial hygienist, suggest that SARS and COVID-19 are outbreaks and pandemics are related somehow to dose, and dose is the function of both concentration in the air and time, and that's why I've started talking more about infectious dose. And I'm not going to spend a lot of time talking about aerosol transmission. I've talked about that in many other settings, and I think more and more today we're beginning to understand and come to the conclusion that aerosol transmission, meaning inhalation of small particles, small infectious particles near a source, not necessarily far away from a source, is really a key feature of transmission for this organism. I've listed here, Matt Evans has a paper, it's a preprint now, I believe it's in review, called Avoiding COVID-19 Aerosol Guidelines, and he has used the concept of infectious dose and derived from novel H1N1 and SARS risk assessments. He's derived an estimate of about 1,000 virions, meaning individual viruses, as a dose. Now, we don't actually know what the dose is for COVID-19, but we do understand that there has to be something about the number of organisms that you are exposed to. It isn't probably just one virion, and it may be less than 1,000. We don't really know. And this obviously it's where those particles land in the lungs. So what size are they, and how likely are they to deposit once they make it to different places in the lung? Well, that will have an impact, as well as what size particles and what concentration particles do people generate to start off with. Today, though, we have a lot more information about that. Here's another recently published article by Lydia Maraska and colleagues called Estimation of Airborne Viral Emission. And they're using a concept called quanta, but quanta is basically another way of talking about infectious dose. And they describe, all of the things that you need to understand to derive infectious dose. And obviously, we don't have a lot of this information. We do have some information about the viral load, meaning the number of RNA copies per milliliter or nanoliter in sputum for SARS-CoV-2 from a small number of studies where people have been measuring in nasopharyngeal and oropharyngeal and sputum samples. We do know something about viral load, breathing, talking, coughing, sneezing overall for people who are healthy, and we have some data from people who are infected with influenza. So we can make some analogies. We do know lots of information about the volume of air that people exhale, the breathing rate of people who are working at different work rates. We do actually know some information about the number of particles that people emit and the particle size, and thus the volume of those particles, which is a function of diameter of particle. So we have a lot of information from other studies and from studies with healthy and infected people that are useful in the context of this. So I'm going to build on top of mostly what Dr. Evans, Matthew Evans at MIT has published, and also what we know in terms of industrial hygienists for modeling. So Paul Hewitt and Gary Ganser published a number of very useful articles, models for nearly every occasion. This is just the reference here on the bottom is just one of, I think there are 5 or 6 different articles that talk about different kinds of models. This first one talks about one box models, very simplistic models that essentially treat a space as a single box. And for many years, industrial hygienists have used these simplistic ways of thinking about concentration, especially under a steady state situation. And a steady state situation would be when you have an industrial process that's creating or generating an aerosol. Well, if you think of people as aerosol generators, which they basically are, and they're a little more mobile than most industrial processes, but that doesn't change the fact that they are in a room generating particles. And so you can use these same steady state concentration equations to derive, and what we know about ventilation to derive what the concentration might be, and then compare that in the context of an exposure limit, which is sort of what an infectious dose is. So I've shown the concentration is basically a function of generation rate, virions per minute, divided by the ventilation rate in cubic meters per minute. And I've listed, this comes from Matt Evans' work. He's gotten these from a lot of published studies of how much volume of saliva do we generate during an individual sneeze or a cough, or during talking over some period of time. And you can, from that information, derive a virions per minute generation rate. Using that information and what we know about ventilation. So in the context of ventilation, what we often know is what we can surmise on the basis of the type of room that we're considering, there are guidelines for how many air changes per hour a particular room should have. That doesn't mean it necessarily will, and so it's better to measure the air changes per hour. But if we can't, we can at least indicate what it should be based on guidelines. And we can easily measure volumes of the room, simply the length, width, and height. So I'm going to use as an example of the typical volume as I found on the internet for a hotel room. My example is going to be a hotel worker needing to enter that room and be safe in the context of cleaning that room after someone has been there for some period of time. So the room volume I found on the internet is about 300 cubic meters. And I couldn't find a lot about guidelines for it, and probably because I didn't look hard enough, but I did find some indication that the air changes per hour in a hotel room should be 5. That does seem high, but because residential spaces are generally around 2 or 3. But I'm going to go with it on air changes per hour of 5 for now. And you can basically use this equation, the ventilation rate equals the number of air changes per hour times the volume of a room, to arrive at what Q would be, the ventilation rate. And I've worked that out here. So giving this example of a hotel room, what's the concentration in this 300 cubic meter hotel room with 5 air changes per hour if you have a guest who's infectious, who's staying overnight? And because we have so many people who are infectious and don't know it, they're asymptomatic. I'm assuming they're not doing a lot of coughing and no sneezing. So, but they're there for quite a long period of time, 12 hours. So I came up with sort of a profile. They're mostly breathing, doing a little talking. I assume they might call somebody up and talk on the phone for a little while, and maybe some periodic coughing. And so you can derive an overall generation rate, and then use that C equals G over Q, that first equation I showed, to figure out what the concentration would be over some period of time. And this is a concentration, as I said, steady state, so it does take a little while before you reach this concentration, but then it maintains. You've got a constant generation of particles, and you have a constant removal of particles by some form of ventilation. Well, if we consider, what that means with respect to a hotel worker, we can figure out how long should they wait for that room to clear, knowing what we do about the volume of the room and the concentrations. And that's this equation here, where basically the time is equal to, is a function of the volume of the room, the ventilation rate, and the initial concentration. And I assumed we would be looking for a concentration that's, say, 0.1 virions per cubic meter, very, very low. So you can use this equation to figure out your wait time, and it turns out to be 84 minutes. So once the person checks out, the hotel worker needs to wait an hour and a half, at least, in order for the concentration to become low enough to be safe enough to enter. And this is assuming, of course, that this hotel worker is cleaning many rooms. So you want this concentration to be as low as you possibly can. That she or he could probably enter this room and work for an hour and not get an exposure that would reach the infectious dose. But you have to keep in mind this person has many other potential exposures during the day, other rooms they clean, other places they go, transportation they're on, the interactions they have with their family. And so I would suggest for this particular exercise, I'm suggesting we want to assure that they really are dealing with a very low concentration. There is, it turns out we've had a lot of the conversation about the aerosol transmission and infectious dose and how to figure out how to protect people has been had in the context of healthcare and Mycobacterium tuberculosis. And I went back to the 2005 CDC guidelines for preventing transmission in healthcare settings and discovered that there's actually quite a lot of very useful information there relevant to ventilation, including this quite nice table that indicates how long do you have to wait to get 99% removal or 99.9% removal based on the air changes per hour. And so you don't even really need that equation. And you can go back and work it out. You'll see that it is a fairly, you don't even need to know the volume necessarily, as long as you know the air changes per hour. I was asked to think a little bit in the hotel example about mixing, and so I did a little research, because mixing factors and safety factors have been used for many years. This well-mixed box model that I'm talking about assumes perfect mixing, but it's true that might not always be the case. So some guidelines suggest that you add this mixing factor basically to adjust your ventilation rate. And it ranges somewhere between 0 with no mixing to 1 perfect mixing, where generally we put values of 0.1 to 0.5. But it turns out, I think mixing factors have fallen out of favor a bit. They're not used as much in modeling. We have better methods of modeling, and if we do think that the one box model is not appropriate, there may be other approaches that could be better. And we also have computational fluid dynamics modeling, which really can take into account many other variables. So as much as this has been a useful way to incorporate lack of mixing or poor mixing in a room, it seems it's somewhat out of disfavor, but I did want to mention it. So we can also use an equation and think about what's the exposure. So what if you have two people staying in the room, one person's infectious and the other is not? You can see how this can easily be applied in workplace settings or other public settings. So we know the steady state concentration is 137 virions per cubic meter. Dose is basically a function of concentration and breathing rate and time of exposure. So if you had somebody sharing the room with this person 12 hours, breathing at a rate of about 10 liters a minute or 0.01 cubic meters per minute, you can work out that they will have a dose of 986 virions. If you recall, 986 virions is not that far off from the 1,000 virions that Matt and others have suggested may be our infectious dose. And I should have included, this is both from Matt and Pat and Paul Hewitt, who gave me this very nice graph to show you the probability of infection. So you can use this equation, 1 minus the exponent of negative dose over that you've calculated over the infectious dose. And again, I assumed that the infectious dose was 1,000 virions. And so you can see that at a dose of 986 virions, you have a 62% chance of getting an infection. So in the context of interventions, and there are many other examples I could work, I just wanted to illustrate how once we do figure out what infectious dose is, or if we just use what we have derived from SARS and influenza for now, there are many ways to use that information to figure out what concentrations might be, what wait times might be, and to explore the differences between the impact of different interventions. So we could look at how many people are in a room, and maybe one of the source controls could be to say you can only have a certain number of people staying in a room. If we could screen guests and actually prevent those who are exposed, who are asymptomatic and infectious, that would be, of course, another really good source control. We don't have those methods yet, but maybe we will. Of course, the thing that most of us are going to be relying on in the context of occupational health are pathway controls, and that has to do with better ventilation. So one of the things that could be done, if it's possible, would be to increase the ventilation rate, which would decrease your wait time. We could possibly add a portable air cleaner to the room. That's a way of increasing the ventilation rate and also cleaning particles out of the room and thus decreasing wait time. You could limit the amount of time that somebody spends in the room cleaning it. And you could also limit the number of rooms that were clean. Those are just some very preliminary ideas of interventions. There are many more that we could think about in the context of this and any other workplace setting. But what I'm hoping to illustrate is that there are some modeling, fairly simple, easy to apply modeling approaches that can give us some picture of what exposures are like and what the impact of interventions might be. And that's all I have to say, Kevin.